a lot of women are now, being quite proactive and trying to get an assessment before they even try and conceive,
pelvic
to get
floor
a bit of a baseline. So awareness is increasing for females, but I guess people don't realise the bowel side of things and the men that we see and pain, obviously related to endometriosis, but any kind of pelvic pain. And men have pelvises and can have pain too.
Welcome to Endo Untangled, the podcast where we unpack the messy, layered world of pelvic pain and endometriosis, one thread at a time. I'm Dr. Alycia Macro, GP, joined as always by my lovely co-host, Cherie, Noble exercise physiologist and birthday girl, and we are glad you're here. I have with me today two special people, Carolyn Berry and Alycia Scannell, who are titled physiotherapists and directors of Adelaide Pelvic Physiotherapy, established in 2021. They support people with prolapse, incontinence and pelvic pain through practical, compassionate care. Carolyn and Alycia bring calm, evidence-based guidance to complex pelvic health concerns. Carolyn Berry, Alycia Scannell, welcome to the podcast.
Thank you for having us. It's exciting.
Before we get started, I just wanted to share a little bit of a story about me getting to know the both of you because we both started our practices around the same time in 2021, probably a little bit before Cherie and I met each other actually, or perhaps around the same time. And I kind of joke sometimes that it was almost like you were meant to become part of our extended family or extended Thrive team because we had met a couple of times and then I ended up sort of coming into contact with your network again, where your husband turned up at my practice in a fire truck. And I thought I might as well share a little bit about that story because once that happened, I thought, we're definitely stuck with you guys. So I sometimes recall that when we first started, and it was pretty chaotic when we started. There was a few doctors. We were all learning what we were doing, or the admin staff were learning. We didn't have an alarm system going, and so finally we got that going. And we had all sorts of computer issues, IT issues. And so my husband, Cameron, came in one day to rewire some of the cabling. And so he was there with an electrician, and they had the angle grinders out, and they were creating all this dust because they were cutting through the concrete in the floor. They'd had to rip up the carpet in the waiting room so they could get under the floor with the new cabling. And the brand new alarm system in this sort of chaotic land of this new practice, none of us really knew how to use either. And the dust that they created from digging up or cutting into the concrete was so dense that it set off the fire alarm. And so, but Cameron, husband, busy with the angle grinder and the electric saw, couldn't hear the alarm. And we had this cascade of different people for it to call. So the next one was me. And I think I was in the car, I was driving. I didn't have my phone on me, so I didn't hear it. And then the next one was the front desk, which is where my mum, Helen, was sitting because she was learning and she was working with us. And so she panicked when the alarm people maybe she didn't even, maybe she could hear the fire alarm going off, which had obviously been going off by some time at this point. The whole practice was full of dust. The practice was still open, ready to see patients, and all of the carpet had been ripped up so that the glue, that sticks the carpet down, was open. And so my mum in the family practice, who'd realised the alarm was going off, didn't know how to turn it off in the hallway where the panel was, so decided to go out across the hallway to meet with Cameron to let him know that it was going off, find out how to turn it off. But because all of the glue underneath the carpet was exposed, she got stuck in the glue. So the alarm's going off, the place is full of dust, the 70-something-year-old receptionist mother is stuck in the glue, at which time I arrived. And because she was trying to get out of the glue so she could go and tell Cameron to turn the alarm off, she fell. So she still had her feet in the glue while being on the floor. And that's when I arrived. And so I walked in the door And then there's the fire truck come with all of the lights going, the sirens, and these men coming in with all their gear on, the gas mask, the PPE, the coat, the big tank on the back. And I was first thing I was thinking is, oh my God, this is going to cost a couple of $1,000 because we've unnecessarily had the fire people out. And the alarm's still going. And I was so apologetic and went up to the captain fire truck man and said, oh my God, I'm so sorry. This is really embarrassing. But, you know, my mum's in the glue and my husband's out there, hasn't realised that the thing's happening yet. And he just lifted his big
visor.
Right. Thank you. I was going to say flap.
Yeah, you were going to say flap. and just said,
and my face was red and I was sweating and whatever. And he's just lifted his flap up and said, oh, are you Alycia? And I was like, what? You know, like, what do you mean, are you Alycia? The doctor. And I was like, and he said, oh, I'm Carolyn's husband. And he was so kind to us because it was so embarrassing. It was so embarrassing. And so from that moment, we knew that you were destined to become part of the team.
Yeah.
So there you go. So I won't continue talking about that anymore.
But they're all very good visuals.
Yeah,
of what happened there.
I know my mum would be horrified that story's been told.
It's all good, Helen. It's all good.
Oh man, the glue. I think her shoes stayed in the glue for a while. Well,
it's just like we wish you could have caught all that on camera.
Yeah.
No.
I would have liked to hear the recall of it by Luke when he got home to say, you'll never guess what I've just said.
Yeah. So bad. So we know a little bit about Carolyn's husband, but we don't know too much about both of you yet, other than you're both pelvic physiotherapists. We'd love to hear more for our audience about you and what you do. Alycia,
yes.
Start with you.
Yes.
You're a physiotherapist. Tell us about what you do and how did you come into this role?
How did I get into this?
Yeah.
I reckon nearly every day one of my patients will say to me, what made you want to do this?
It's
and
not something
they often have this funny look on their face. It's like, why are you doing this for a job?
Yeah.
But I love it. And I think the way I got into it, I was working in a public hospital probably for about 7 years to start off with. And when you work in a public hospital, you have to go and do all your rotations. And the hospital I was working at had a maternity ward. And anyone who knew me before having kids, I was super clucky. I mean, since I've had kids, I'm not. Not so much. And so I always putting my hand up to go and cover the maternity wards so I could hold the babies while I'm showing the women their exercises. And so when you're speaking to postnatal women, you know, all the time, you really get a feel for what they're going through. And so it's natural progression to talk about pelvic floor muscles. And that's what got me started into pelvic floor work and women's health. But now I actually enjoy any kind of pelvic health, so men and peds as well. Mm. So it's been a nice progression that where I was working, there was a senior women's health physio, Maren, her name was. I'm sure I can say her name. And she really inspired me to start the proper pelvic floor work and work in outpatients. And she was a bit of a founder in using EMG biofeedback for pelvic floor work and pelvic floor assessment in the hospital that we were working in. So then I progressed from there. So, and we've been working in private practice. I've been working in private practice probably about 15 years, I think, since my last child was born. And then Carolyn, I'll probably hear me say Kaz all the time.
It's okay.
And then we met each other working in a private practice. I can't remember how many years that was. And we gelled. I had a good feeling straight away that I like this person and we've got similar values, similar interests. And then Kaz and I started our own business 2021.
So what about you, Carolyn? How did you come into this work?
Now you're calling me Carolyn.
Yeah. Oh, sorry,
Kaz. We might need to say
Kaz. We'll
Just
say
call me
Kaz.
Yeah. Mine actually started really as a student. So in our final year of physio, at that point, physio only had one course here in Adelaide, which was at UniSA. And there was one lecture by Trish Newman in fourth year on continence. It was on stress incontinence, actually.
Can you just tell us a bit about Trish Newman? Because I was going to say, both of you have worked with some of the kind of godmothers
Trish and
of this
Jenny.
field.
Yeah. Trish is quite an inspiring woman, really. She and one of her very good friends, who both Alycia and I worked with, Virginia Gill, who was the head of UniSA, was head of school for a period of time, wasn't she, at UniSA?
Not sure, head of school.
Or was she fourth year?
She was involved in the fourth year
university.
placements and things like that, I think, yeah.
They definitely pioneered work in continence physio in all of South Australia, really. And Trish went on to do her specialisation, and both of them were involved in research, and very incredible and generous mentors. Very much welcomed us into the fold, and it just very generous with their time and with sharing their knowledge and experience, which that actually was really part of a motivating factor of continuing to progress through this area of physio. So, she gave her lecture. She was passionate. She, desperately wanted to share that, this had grade A, level 1 evidence for curing people and changing their quality of life. And I'm like, wow, I want to do that. So we got to do an elective in fourth year. So I chose to do my elective at the Women's and Children's. And that kind of, opened my eyes to the area. And then I got a new grad position at Flinders Medical Centre, and it was meant to be because the late Steph Cooper was the Women's Health Senior and she was the new graduate mentor. So she just kind of took me under her arm and said, right, we're going to do this. When I did my, again, public hospital, so you do your rotations. So I did a rotation in outpatients, and she's like, you're going to start seeing the postnatal women and doing the back care education, and she'd take me up to the gynae ward and take me to the postnatal ward, and it just evolved from there. And both Ginny and Steph were at Flinders and were great mentors through that time. And Ginny was who I started, and that's who Alycia worked for privately. And
it sounds like the road was paved for both of you in separate and then together.
I think so.
Absolutely. Yeah.
And then to us in a fire truck.
That's right.
In a fire truck. That's right.
What an entrance.
Before we move on to some other questions, I was interested to ask you a little bit about training, because I think that's important as we progress our discussions around pelvic pain, is I think there's a lot of people don't really understand what the postgraduate training might look like for physiotherapists and what it takes to be a pelvic physiotherapist. Who would like to talk to me about that? Kaz or Alycia?
You know more about that. Look, I think when we were starting and wanting to become more and more involved in pelvic floor work, what was available at that time is a bit different to what's available now. So when we made the decision that we wanted to get a little bit more credentialed, I suppose, and challenge ourselves into this field of physio, we went through an experiential titled pathway through our APA. So that involved a lot of preparation, meetings and sessions, trying to increase our knowledge and aware of the research. And then we had to, when we thought we were ready, we had to do assessments and film ourselves doing examinations. And so that's how we became titled. Now, that was a while ago, so it's quite different now.
Well, probably when we even became trained in doing, let's talk at internal examinations, right? So that's not part of an undergraduate course. At that point in time, the only way to learn was through doing courses. So we did a course. Actually, you did Trish and Ginny's course?
Yeah. And even in Newcastle, there was Pauline Chiarelli, which was a long time ago.
Yeah. And then the expectation was you would be mentored. So we both had the benefit of being in public sector, so teaching tertiary hospital, so we could have that ongoing training and mentoring. Now, what is available is there is 2 postgraduate qualifications that you can either do in Melbourne or in Western Australia. And that's
like a master's, isn't it? Is it a couple of years worth of postgraduate study?
Yeah.
Because I think there's obviously different levels of qualification and experience that a physio might have working in the women's health area.
There is also the pathways through the APA. So there's a level 1, level 2. So, and that is what is been developed over the last few years.
Yeah.
And so you can go through that way as well. But it's very much making sure that we're keeping up with all the evidence and the research and being assessed and having your skills credentialed. Yeah. But you're right, there are some physiotherapists that have a real strong interest in women's health, and they might want to do a lot of work with postnatal, antenatal, but they may not have the experience or the credentialing to be able to do internal examinations. And so, but there are steps that they can take if they wish to do that. But not every women's health physio is credentialed to do internal examinations.
I think that's a really important point to establish, and is probably a good segue, if I can take it, into like what actually is a pelvic floor physiotherapist. And you've sort of identified the, I guess, delineation between a women's health physio who can perhaps do some examinations and assessments and treatments. However, that would differentiate from the level of experience and knowledge and credentialed of a pelvic
or pelvic health. I think
pelvic health?
A pelvic health physiotherapist.
Yeah. So do you want to talk to us about exactly what is a pelvic health physio?
Yeah.
Well, we had a good think about this, didn't we?
We did.
Do you remember what we were talking about?
No, I do. So I think we're interested in that. So as physios are interested, and often the language I use with patients is we're interested in muscles and bones, right? And so when it comes to a pelvic health physio, of course, we're interested in the pelvis. So that includes the spine, that includes the pelvis and the muscles that attach to the pelvis. But we're also interested in what's in the pelvis. So the bladder, the uterus, if they're identified as female or female at birth, and the bowel and the prostate if they're a fella, because we do see men. And that's across the lifespan, so including kids as well. So we can see children with bladder and bowel dysfunction and toileting issues. And
it's probably not something that is spoken about a lot. Hopefully we're getting better at discussing these types of issues and conditions within the body and what's normal and what needs to be checked. And I think we've found, as you probably have as well, a lot of people initially with, because we're here to talk about endometriosis and pelvic pain, thought things were normal and didn't know. So I think that's, it's such a...
Yeah, a lot of, in terms of not knowing what's out there, a lot of patients that come to see us, they say, I had no idea there was someone like you that we could talk to about this type of thing. And it's often the GPs or their specialists that have referred, but I suppose now they're hearing more about it on social media as well.
So when should you come and see a pelvic health physio?
That's a great question.
Wow. It could be if you have any concerns with any discomfort, pain, dysfunction with your bladder.
Before any
before and after surgery.
During the antenatal period, after childbirth. Even you don't even have to wait till that childbearing time frame. A lot of women are now being quite proactive and trying to get an assessment before they even try and conceive,
pelvic
to get
floor
a bit of a baseline. So awareness is increasing for females, but I guess people don't realise the bowel side of things and the men that we see and pain, obviously related to endometriosis, but any kind of pelvic pain. And men have pelvises and can have pain too.
One thing I wanted to ask about is I think where I come across people in clinic who, if I mention a pelvic physio, I can almost see their mental picture of perhaps almost like a veterinary sort of situation with kind of gloves that go up to about past the elbows, and there's a lot of kind of both hands inside. And I just wondered if you could tell us a bit about what an appointment might look like if you go to see a pelvic physiotherapist. And do you have those big veterinary gloves involved?
Are you standing there with the probe at the door?
No,
Absolutely not. Absolutely
Sometimes even the first appointment you don't
do an examination.
And I think this is where you have to get to know the person sitting in front of you, and they need to have enough of a chance to know you and get to trust you before they would feel even happy to contemplate having such an examination done. But I normally find, and Kaz, I'm not sure about what you think, is when you've had that chance to really listen to their story without interruption as much as possible, and then you've been able to give them some information about why you think they might be having some pain, and if an examination was needed, why, what would we be looking for in terms of having an examination. Normally by that time they're really keen to go, right, let's look. Let's see. I wonder what my muscles are like. And then, but you have to read them, because sometimes there are women that you can tell are on edge, I think. And sometimes I've sort of picked up vibes, and I've actually said, look, we're not going to do an examination today. Let's just chat and you tell me your story. And you can see them go, oh. And so then we get a bit more information, and then we might talk about feeling comfortable to do it the next time.
I think it's the education around the examination process. But before you even get to that, you've ask questions, and I often show my pelvis, and I'm like, look, in here we've got
the
bladder.
Model of the pelvis.
Yeah, the model. Sorry. My hands.
We should have brought a model.
We should have brought a model. Showing that what's in the pelvis so they can see, and why I'm going to ask questions. And I often say to them, I'm going to ask questions about your bladder. I'm going to ask questions about your period and about vagina and about
sex,
intercourse and about your bowels, and because it all relates. And but before I've even done that, one of the first questions I often ask, and we were talking about this, Cherie, is, what are you hoping to achieve from today's appointment? Because everyone's going to walk into the room with different expectations. Some come, and I often say, you see these kind of blank eyes, and I said, are you doing your due diligence because your doctor said you should come and see a pelvic floor physio? And they're like, yeah, that one. Yes. And I'm like, right, that's great. I'm so glad you're here. And do you know why they probably sent you is because there might be something going on here, and I'll have a bit of a chat and ask them some questions, and they're like, and you can see we're putting the dots together, and they can, see, okay. And then I might eventually go, okay, so what do what might be some of your goals? And so then you can link it back to their goals. Well, I need to look at this, and it might be doing a bladder diary, because one of the things they say is, I'm weeing every half an hour, and I'm like, well, let's look at this. Let's, get some objective information, so I can then link an examination to what their goals are, because I need to look at this to,
to find out.
Yeah.
The other thing too, if we do decide and the woman is happy to have an examination, I always make a point of just telling exactly what will be involved. Some of them have had transvaginal scans, had attempted speculum use, and maybe a little bit traumatised, not by this GP at all. No. But
certainly possible, perhaps in the earlier days. Yes.
But I'll one of the first things I'll say is today I'm not, especially with the pelvic pain, I'm not going to use a speculum, just gloves and gel and probably only one finger if you're comfortable, and you're going to tell me when it's okay to proceed, and you can stop at any time, so that we pass the control on to her as well.
And that's really part of that informed consent, isn't it? Because consent is really, that's essential.
Yeah.
So they need to understand what you're doing.
Yeah. And once again, there's such a theme with the practitioners that we work with, and it is around this individualised approach, listening, informed clinical reasoning, and just it's often how you're doing something, not necessarily what you're doing, but how you approach it as well. So,
it's the relationship, I think, that is, I can't remember the percentages. There is a study on, there is a study that has shown
therapeutic relationship.
alliance, is it, is responsible for a certain percentage of.
What percentage is that,
Don't
Alycia?
ask me that. I don't know. But
You can't bring facts to the table.
A significant percentage of improvement or outcomes are linked with the alliance that the therapist and the patient have. So,
and just to explain for the listener, the giggles there were that Alycia in particular did need some convincing to come today because she was quite concerned that there would be
tested.
This was going to be like a viva around evidence-based treatment.
Yeah.
And she would need to know and be able to quote accurately studies, journals, specific
And I
statistics.
hadn't had enough time to read up on all my
It was a
latest
panel
journals.
interview. And you will be graded.
Yes. So,
But
some of that information will be...
this is fun. This is not what I was imagining. So this is great. Happy to chat.
Good. I did, just for the audience, have to promise to take you all out for dinner afterwards.
Correct.
So
That may have helped too.
yes, okay. So what we're here to talk about principally is pain and pelvic pain. And it actually, as a GP, surprises me because when I see people with endometriosis, pelvic pain, I often see people who've been in the system and seeking help and care for a long time before they come and see me. They might have had multiple surgeries. They might have seen multiple different GPs, non-GP specialists, different allied health practitioners, different alternative health or complementary health practitioners, and done all sorts of things. And I almost always ask in the initial visit, have you seen a pelvic physio before? And it actually really surprises me how often they say no. And so I thought it might be really helpful as a starting place is you mentioned, Kaz, muscles and bones. That's the physio's job. Where does pelvic physiotherapy fit? This is a big question. Where does it fit, well, both of you really, in managing someone with pelvic pain? So someone who's listening might have had pelvic pain for a long time. Why physio? What are you going to do for these people?
When you're talking about, let's just put one of the facts of pelvic pain and endometriosis. So I think for anyone who's not aware, and I think a lot of people, the awareness is growing, that the diagnosis of endometriosis does not equal someone's pain. So the disease process in and of itself, we can have someone who seeks, for example, a laparoscopy and has the diagnosis of stage 4 endometriosis, and they're bewildered and they've sought that because of perhaps infertility and they had no pain, versus someone who, has minuscule, I don't like using that word because it then, helps diminish someone's experience, but the disease doesn't equal someone's pain. And in fact, people can have pelvic pain without the diagnosis of endometriosis.
100%.
So I think when someone presents with pelvic pain, and whether that is anywhere in this region, it could be abdominal, it could be sacral, it could be in the bottom, it could be vaginally, it could be pain with sex, it could be pain around their period, around ovulation, it could be present in a variety of ways. I feel our role is to help work out what the main driver or drivers of their pain is. And if we think of the complexity of the pelvis, unlike other areas of the body, the pelvis has muscles and bones, which we know can be sources of pain, right? We know that there can be referred pain from these sources as well, but it also contains three, for a female or a female assigned at birth, it contains three very important organs that also can be sources of pain that have a different nervous system innervation. So they have an autonomic nervous system. And so that's our fight or flight or our rest and digest nervous system. So that's the bladder, the uterus and the bowel. And we've got a nervous system, so our brain, our spinal cord and our nerves, and then we've got the muscles and the joints. So I think our role is to really, with good questioning of all of these areas and with good clinical reasoning, and then further examination and investigation, our role is to try and work out what the main driver is and what the other contributing factors are, and then bring knowledge, because I think a lot of these patients walk through the door and they come from a variety of experiences, and some of them, you know, feel like they are completely broken and they feel overwhelmed, confused, have been told, unfortunately, different things from different health professionals, rightly or wrongly, or their interpretation of what they have heard is, but that's what we need to deal with, right, is what is their understanding and try and work out what their understanding is and help them see that there's hope and that there's things that we can do. And we may not be able to, you know, I never promise to eliminate someone's pain, but I want to give them a toolkit to give them some autonomy and agency over, okay, there's some things that I can do that might make this a bit better. That's our job.
What's your biggest challenge with that?
There's lots.
Yeah. Is there one that sort of comes
I think
to mind?
it's, you know, straight away if someone comes in and they're very medically focused and I find it hard if they are relating every sensation in their pelvis to something pathological.
Do a bit of endo or an ovary or
yes,
so
endometrium.
They know they might have a bit of endo on their ovary. So that's why I'm particularly having that pain at that time. And I find that really challenging. Because,
and you've just said about how complex.
Yes.
And I think people probably don't appreciate the complexity of the pelvic area.
Well, is it that they don't appreciate? I just don't think they understand.
Yeah.
And I think what people really struggle to get their head around is that pain is a conclusion that our brain will decide as to whether what we experience and at what time and at what volume. And so there are influences that can dial that experience up, but there are also plenty of things that can dial that experience down. And I think if we take it away from the pelvis, we can talk about phantom limb pain. How is that possible? They don't own, their arm's not there anymore. How can they feel that they've got an arm? And this is where you can start to try and get a little bit of buy-in that, you know, what we think and the influence of external factors, stress, how much sleep we've got on board, what our hormones are doing. Like, it's all of that role of education and trying to find whatever buy-in you can get to create a new level of understanding for that person. And some people will just not be ready to
take that on board.
Take that information on board. And actually, I'll often say, you know, that's actually okay, right? Because at whatever point they're at in their journey, they need to feel ready and they need to feel safe. Like I talk a lot around safety and, you know, changing their experience so they can actually experience different sensations in their body and give their brain a different story and different pathways to lay down.
Sounds like you meet people where they're at.
Yeah.
That's a good way.
You guys do such beautiful work, all three of you actually. I gather from what you're telling me, and obviously this is something that I'm aware of because I work with it a lot, but someone listening to this may be new to some of these concepts. If you're meeting someone and it sounds like you're doing lots of listening, when someone might be explaining to you what their symptoms are and how their symptoms show up for them, what sort of things might they be saying to you for your pelvic physio ear to be thinking, oh, I think that some of their pain is coming from
other factors?
Yeah, particularly, I guess, to start with, we can talk about other things as well, but particularly what might make you think pelvic floor might be causing some of this pain rather than sometimes there is pain caused by lesions of endometriosis, for example. What makes you think, oh, that sounds like, in your opinion, musculoskeletal pelvic floor pain? Because I think that's something that'd be really nice to hear more about.
Yeah. I think probably if they're complaining of certain pain that is with certain movements or after prolonged positions, because generally if it's endometriosis-related pain, or more hormonally, it's they can sort of pick up a pattern, whereas musculoskeletal pain could be sharp stabbing pain. It could be difficulty having intercourse, particularly more superficial intercourse, because I think women with pelvic pain or endometriosis may have deep dyspareunia, which may and that is painful sex.
Yep.
Sorry,
yep.
We're here to validate you. It's all good. Like,
but I think it's more the women that say, I feel like there's a blockage when I attempt to have penetration. That makes my little physio ears go, okay, I wonder what her pelvic floor muscles are like.
Mm.
What else? They might also, if they are doing lots of core exercises or they're doing some sustained exercise that might be recruiting your pelvic floor a lot, that tends to make things worse. And sometimes they've also worked out what positions feel better. So, they've found some yoga poses or some resting poses that help to ease their pain. Heat can help in a lot of ways, but if heat makes their pain better, then there's a good chance it's helping with muscle relaxation as well.
I would also add challenge with using tampons, difficulty with their bowels, difficulty with emptying their bowels, pain with emptying their bowels, perhaps a history of maybe even they've had fissures or hemorrhoids.
And even with the bowels, they'll often, this is what again pricks my ears up, is they'll say that their bowels, they've got a good urge, they've got good consistency. So it's not that they've got very hard pebbles and they're typically constipated in the true sense of the word, but they can't get it out. So it's more obstructed defecation. So that could be that the pelvic floor muscles around the back passage aren't relaxing properly when they're trying to open their bowels.
Yep.
And the same with the bladder, so voiding dysfunction. So because we often ask lots of questions about the bladder, they'll say, I've got lots of urges to go, which might be just a sensitive bladder. And I think we'll talk a bit more about that down the track. But it also could be that when they're sitting on the toilet, they're not able to relax their pelvic floor muscles to send the right messages to the bladder to contract.
Well, then they say, I've got to go back 5 minutes later because I just felt like I wasn't empty.
What about things like, sometimes I hear people say that they're getting thigh or leg pain, hip, back pain, stabby pains as well. Stabby pains is something that makes me start thinking, someone called it lightning ass, which we shouldn't laugh. Well, it's a funny term, but it's a very painful thing. And if you're listening to this and you have pelvic pain, I bet you'll go, oh, yes, I've had those. And the vaginal lightning vagina, I think we'll call it as well.
Yeah.
Those ones as well.
Yeah. So you can get, I think pelvic floor muscle spasm can feel like a really bad pelvic pain, period pain, I should say.
It's
normally
very
more low and central.
Very low, yeah.
But then you can get, there's muscle called obturator internus.
Okay.
Which is a muscle. It's not technically a pelvic floor muscle, but part of the insertion is inside the pelvis and the other insertion is out on the hips. So you can have tightness and myalgia, which is painful to touch, in those muscles, and that can often bring about pain on one side of the pelvis more than the other, again instigated by either prolonged positions or certain activities. And often when you assess those women, they can be particularly tight in their hip range, in their range of motion, particularly internally rotating at a certain position. So that's the other thing we'll do. We'll not just check their pelvic floor muscles, but we'll check their range of motion of their back and their hips to see whether those muscles might be contributing. But it's the stabby pain on one side that also pricks my ears up about.
And is there a
muscles.
side that is more common?
No, I don't know.
think so.
I don't know. So it's different to ovulation because sometimes, women can say, I know when I'm ovulating because it can swap side to sides. But that's at a certain time. That's always 2 weeks before they're due to have the period. But this, look, it could be maybe on one side if they might be deficient in some other muscle control on that side. And so obturator internus might be trying to compensate. But that's why it's good to look at the whole person. It's good to look at their gait.
And also talk about that more big picture. Where else do you get pain? Yeah. I sometimes think that the pelvic floor might be on and tight. You start questioning them and they get headaches, or they're a jaw clencher. They wear a mouth guard at night. They've got neck pain. They, and then you start asking these questions and I'm like, you're a person who's on. And they're on everywhere.
So the other thing that I think people think about, well, we're just exploring what pelvic physios do. And one observation I think I might make, because I came into medicine later in life. I was 26 when I started medicine. I'd worked and done other things.
That.
Oh, there you go. I'm a late bloomer. But I feel like, and I think I've discussed this earlier on the podcast, that I have had endometriosis myself. And it wasn't until I was, almost all the way through my medical training before the penny dropped for me. But I tell you what, I had years where, and this was 20 or more years ago, that it wouldn't have even occurred to me that there would be a health professional, not only who I could go and talk to about this stuff, but who's actually comfortable and open and non-judgmentally happy to talk about wee, poo, sex, pain in funny areas. Yeah, so I think for those listening who are wondering whether it might be useful to see pelvic physio, I think it is a very, as you, in your words, very safe place.
And part of an informed consent, one of the questions I ask, if it hasn't already come up when you're asking about intercourse, is has there been a history of any unwanted sexual experiences? And depending what comes up, and often, once they feel quite safe in sharing that information, then they disclose, actually, that often I will then go, okay, so, thank you for sharing that. And I'll often ask them, how would you like me to document this in your notes? And then I feel like that's a good opportunity to say, not always, but often this can be, creating a level of protection very subconsciously, because our body holds on to that. And that would be a time where I'd be like, yep, their pelvic floor is probably going to be in that protective mode.
And it's not only unwanted sexual experience, but sometimes it's from a medical procedure as well. They've been traumatized, and that can still bring about the same types of sequelae as
even
sexual.
Around birth trauma too. I think that's significant too.
Birth trauma is a big one. And really any sort of trauma. It may not have even been a sexual trauma or an unwanted sexual episode. It can be any trauma. And anything that makes the body want to self-protect is certainly a risk factor and a trigger for pelvic pain. And many people I see as a GP will have that conversation with me around if they're seeking a diagnosis for endometriosis, or if they've had a laparoscopy which may have found any degree or no endometriosis, is that idea that different things can set this problem in motion, and what endo is one of those things. Sometimes it's more than one, but it could be birth trauma, it could be a traumatic medical examination or similar. It could be many things. One of the other, we were talking about flags that you have around the pelvic floor and the way that might show up. One of the other things that I'm interested in, and I'm not sure about the level of scientific evidence around it, how much of this work has been done, but I'm interested in your thoughts around, and we've talked about the hypermobile person a little bit in previous episodes, is how often there are hypermobile people that we see with complex pelvic pain. Is how do you think the hypermobility may affect someone might be driving or could be driving pelvic pain or contributing to pelvic pain? Any thoughts on that as a physio in terms of biomechanics around that?
There might be, I think everyone's so different, because I definitely see one of our questions on our intake questionnaire is, do you consider yourself hypermobile? And so, and a lot of them do say yes. And to be honest, a few years ago, I wasn't taking as much notice of that as I am now. So if someone says that they're hypermobile, then they normally would also offer, I've had problems rolling my ankles, I've had back pain for such a long time, I have had lots of pain and injuries. They also might have bowel dysfunction as well. So, and then I'd also ask, have you had an investigation? Has there been any diagnosis of Ehlers-Danlos or anything like that? But bring it back down to more of a muscular control. If they're hypermobile, say they've got hypermobile hips, then they might be recruiting parts of their pelvic floor in compensation. So then, particularly obturator internis, so then that might be linking or, increasing that tone in their pelvic floor.
Yeah.
So try to compensate for stability. Yeah. And this is where I know we're going to talk about myths. Do we have that written down? There were some myths that we wanted to talk about, but
go for it. Let's talk about myths that you see.
It just made me think about something that Kaz and I were talking about is, I think as pelvic pain is becoming more and more, the awareness is increased, there's a lot of women, I think, that have been told that if you've got pelvic pain, then you definitely have overactive pelvic floor muscles, and that must be happening, and you must stop doing this and this and this.
Yeah,
and
that's so common.
And I think for some women that might be good advice, but for what I'm finding is that there's a lot of women that they don't have pelvic floor overactivity.
It's not the main driver.
It's not the main driver of their pain, and they're craving to get back to the gym, and they're craving their Pilates classes, and because that's what made them feel good. They had social connections. So that's one thing I wanted to say. So not everyone with pelvic pain necessarily has tight pelvic floor muscles, and I know not everyone has the ability to have access to have a pelvic floor muscle examination, but it is very handy if you can, before you make changes like that, to make sure you're doing it in the right way.
Especially the patients who are hypermobile. They actually need the strength training and the strength through their great range of motion. And
not necessarily giving them pelvic opening stretches.
Correct.
As a recipe. Because I have found lots of women who have started doing those, but when you test their hips, like they
don't need
stretching. They don't need any pelvic opening stretches.
Yes,
they might be tight in the obturator internis. So when you try measuring how far they can internally rotate, that might be something to work on. But so that's
it's not a one size fits all.
It's not. No, but that's the same with everything, isn't it? It's just got to listen and treat everyone differently.
Yeah, and I definitely see lots of women now who have done lots of stretches and they say, I've done all the stretches, I've done all the homework,
and
it isn't making a difference. And it's like, okay, let's revisit that. Are we? Have you been going down the wrong path for a little while, or not? And everyone's going to be different. And one of the things that you've both talked to me about is when you're checking someone's pelvic floor, there's multiple things that you're looking at, but you're looking at the tone of the muscle.
That was the other thing we were talking about.
And you're looking at whether it's sore as well. Can you talk to me a bit about what things do you look for in a pelvic examination, as particularly when you're looking at the muscles?
Resting position in relation. I wish I had my pelvis so I often will start, once I've done my anatomy lesson 101 with the patient, I often start when they're up on the bed, and I've often done a bit of an education around the pelvic floor is the bottom of your core, and the lid of your core is actually your diaphragm, because that language of core, I'll often say, most people hear this word core and it's a bit of a buzzword in the exercise industry, and most people think core is this, and it's our tummy muscles and it's doing crunches and planks. And whilst there's a level of the abdominal muscles that are involved in the core, when I'm referencing core, I'm referring to your deepest muscular level of support. And I like to think of a cylinder, so I'm talking about the lid of the cylinder is our diaphragm and the base of the cylinder under is the pelvic floor, and the two work synergistically. So that kind of, I'm going to actually start looking at your breathing first. So it gets that buy-in as to why we even look at breath. So I'll look at the way that they breathe, and then I'll look at the base of the pelvis and look at the perineum, which is the area between the vaginal opening and the back passage, and I'll say I'm going to pop my thumbs on your sitting bones. So I'll put them on the ischial tuberosities or their sit bones, and I'll look at what's happening when they breathe. And resting position gives amazing instant buy-in to if they're sitting up here or if they're sitting way down, if we're looking at a prolapse patient, or if it's sitting pretty, and if we can actually see movement of that perineal body with breathing. Their inner thighs also are a telltale sign too. I know we've talked about that before, Alycia.
Yes. And perhaps if you're listening to this, if you do have a lot of pelvic pain, you don't need to do an internal on yourself.
No.
But even if you have a little feel of these muscles, the adductors, the ones on the inside of the thighs, give them a little bit of a press. How sore are they? They're not meant to hurt. And if you're peeling yourself off the ceiling right now, that gives you a bit of an interesting insight into what else might be going on, because of course those adductor muscles, they're not pelvic floor muscles, but they attach to the pelvis.
They're in protection mode.
And often I'll use my thumb. I'll say, look, like this is a muscle that's relaxed at rest, and I can press it and it doesn't feel sore, and it's got flexibility and give. And how much flexibility and give is going to vary from person to person, and it depends on their tissue. And when the muscle is tight and you touch it, it's firm to touch, but it shouldn't be sore. And so then I might, so the next thing I might do is a cotton tip test looking for any areas of hypersensitivity, and then I might rest my thumb externally just on the muscle body, on the perineum, and, assess tension in the tissue, assess pain, because you want them to feel safe. And I'm often saying, is this okay? And I've already prefaced, anything I do shouldn't cause any pain or discomfort. So if you feel vulnerable at any point, you ask me to stop straight away.
I think there also is a tendency to link a tight muscle, if there is a tight muscle, that it must be painful. But that's also not true.
That's one of our myths.
Yeah. So you can have a muscle that I also use my thumb to demonstrate, a muscle that when you touch it, it's I say it's spongy. It's got some give in it. And to me, feeling it, it's like, oh, that's fine. That's normal. But the patient saying, no, that's really, really sore. Yeah. So in that situation, I don't think it's muscle tension that's the driver. It's sensitive muscle. It's being sensitized. It's still sending messages and it's real pain, but it's not the tension of the muscle that's driving the pain. So I think that's another important distinction.
Did you have any, because I knew that we would run out of time, and we are so running out of time, but I think what we'll do is get you back. I feel like it won't be as hard to get you back this time. To get you back so we can kind of do a part 2 of this, because I think we're going to need a second part to this episode, because we're just scratching the surface now. I'd love to hear in our last few minutes that we have is if any other sort of big myths that you wanted to talk about.
That you should drink 2 litres of water a day.
Okay.
That sounds like it needs to go in the bladder episode.
Yeah, it does. It does. Just bookmark that one.
But then that's tricky too with all the pots.
Yes.
It is.
Yes.
But that's why we need to talk about it, right?
Yes. But that's a tricky one. And
if you're constipated, you need to drink more. I think we need a whole episode on bowel.
Bowel definitely
is coming.
You mentioned a lot around safety, consent, talking your patients through the consultation, which is just so imperative to a good consultation. And it sounds like your consultations are for everyone. Is there anyone that shouldn't come?
Is there anyone that shouldn't come?
Like
I don't think. No, we would welcome anyone in terms of what we would do in the consult. So there's definitely cases where you wouldn't do an internal examination,
or it'd just be then a referral on to So it's always a good. I guess my point is it's a good starting point.
Yeah, I think if they've come to the appointment, they're often they're wanting some information.
Yeah.
So depending on what stage they're at, they might be just read on social media that it's good to get a pelvic floor check, or they might have been sent by their gynecologist. But I think it's always good to run through from an education point of view and just discuss the normal function of all our pelvic organs to see if there's anything that we could maybe pinpoint that might prevent issues from, evolving or increasing down the track.
Yeah. And I guess I just want to remove any barriers.
Yeah.
I think we were talking about this, Carolyn, before we started, like what are the barriers for someone coming to an appointment? And I feel like we've addressed a lot of those. And I do want to bring up just one of my favourite topics is neurodivergence.
Yeah.
And whether you do see a lot of that and how you can tailor your consultations for look, I guess a term that's being thrown out there is neuroaffirming, but do you see this population and are you accommodating for that?
Yeah,
a growing number.
Especially, yes, a lot of them have already got it diagnosed and already been treated. I find the females, they're often very high functioning, obviously.
Yeah.
But when we're talking about so much information, I always will have a notepad that I write everything down. Everything that we suggest, I write it down, and I keep a copy. And I think it's often the neurodivergent client that are very appreciative of having that written down. Yeah, just not bombarding them with too much information at once.
And I think that's where you've started early on to ask what are they hoping to achieve from that appointment and any kind of education. Often I'll pull out their phone and I'm videoing different things for them so they've got different ways to relate, because sometimes I write everything down, Alycia and I both do. But, that reading, that scroll of stuff sometimes is not the way that they learn information. And so, lots of visual cues and videos. But I think that comes back to just trying to treat everyone individually and trying to work out what they need and what's the best way for them to understand that, because that actually looks different for everybody regardless of diagnosis or not, I think.
That's amazing.
So, Kaz and Alycia, I think we must come back for part 2 of this podcast, which I think needs to cover, okay, if someone does have a very painful pelvic floor, whether or not it's over or active or not, what might be a place to start, or where might you start, and why do we talk about the breath and breathing? Why is that important? To talk about painful sex and the way that you might approach that, to talk about bladder and bowels, again, in a little bit of detail, but they also need their own episode. So before we wrap up today, some final thoughts. So if someone's listening who is suffering a lot, and we sort of, I guess, know what that might look like, and we see that a lot. If you could let them know one or two things today, what would it be? What would your message be?
Well, I'd say that if you've been having pain, persistent pain, there's hope, definitely. It's changeable. Your brain is a very powerful thing, and your brain will help you learn new ways of dealing with it and dialing down the pain. I'd also this is where I might give a little bit of a plug. I've just read Susan Evans' newest book. It was Endometriosis and Pelvic Pain for Teens, I think. And I actually think it's for teens, good for teens, but also good for other people. But it just helps to really summarise and clearly explain all these terms, where pain might be coming from, drivers, pelvic floor. So that would be something I'd suggest. I've actually, since I've read it myself, sent the link to many people.
It's a great book.
What about you?
Yeah.
Any final thoughts?
So I suppose not only that there's hope, just to try and change their language around they're not broken, because the way that they think about their pain can change their pain. And I was going to say the book too. Yeah. And
Well done, Susan.
Yeah. It's quite concise, but it's very great. Yeah, it's really.
And the Pelvic Pain Foundation is a great source of information as well.
Well, thank you so much, Alycia. Let's come back for part 2.
Okay.
And thank you so much for listening, and we'll see you next time.
Thanks for having us.
Thanks for having us.
Bye.